Good evening, everyone. So, on behalf of Northeast Online Nursing Coaching, I welcome you all on this online platform. So, today I will be discussing on some few MCQs on obstetrics and gynecological nursing. So, before going to the MCQs, let's just see for few basic terminologies. That is obstetrics. Obstetrics means which focuses on pregnancy and the childbirth. Whereas gynecology, that means it deals with the female reproductive system. And the andrology, that is, andrology means the study of male reproductive and the male reproductive system related problems. And midwifery, that is the practice of providing care to women during pregnancy, childbirth, and the postpartum period, and often by a midwife. Okay, so let's see the basic things first. That is the female reproductive system. So we all know the female reproductive system. There is external and the internal reproductive system. In external, that it includes the vulva. In vulva, where there are like clitoris, labia majora, minora, and the vaginal opening. Whereas in the internal, there is the organs like you can see from here the ovaries, fallopian tube, then the ovaries, fallopian tube, uterus, cervix, and the vagina. Okay. So next is the basic concepts. The basic concepts of male and female reproductive system. You can see as a difference also. Like the primary sex organs or the gonads in the female reproductive system, that is the ovary, whereas in male it's a testis. So the primary function of the gonads, there is the what they will do. There is the production of eggs, that is the ova, and there is a site of fertilization, nurturing, and also the supporting of embryo or the fetus. And in male, there is the production of sperm, delivery of sperm for fertilization. And the gametes produced from the ovary, that is the ova or the ovum, that is the egg. Whereas from the testis, there is the sperm. And the gametogenesis. Gametogenesis, that is the, in case of female, there is a, which is called the oogenesis. And in male, that gametogenesis process, that process is called the spermatogenesis in case of male. Okay, so gametogenesis means the process of producing the gametes. Okay, so that is the process of producing the gametes. In female, we call it as the oogenesis, and in male, it is the spermatogenesis. So the lifespan of the gamete, that is 12 to 24 hours. That is half to 1 day in female, and in male, that is the 48 to 72 hours. That is in case of days, that is 2 to 3 days. And the sex hormones which are released from the ovaries are estrogen and progesterone, whereas from testes are the testosterone. And the age of puberty, that means puberty means the development of the secondary sexual characteristics. That in female, it starts from 10 to 16 years, whereas in male, it's starting from the 12 to 17 years. So the first sign of puberty, in female, that is a breast development, which is also called the thelarchy. And in male, it is the first sign of puberty is the testis development. And there are internal organs and the external organs, which I have already told before, like internal organs like ovaries, fallopian tube, uterus, cervix, vagina. Whereas in male, the internal organs are the testes, epididymis, vas deferens, ejaculatory duct, and the urethra. And the external organs in female are the vulva, and whereas in male, that is the penis and the scrotum. And there are some accessory glands. There are the Bartholin glands and Skinner's glands, which are seen in case of female, Bartholin gland and Skinner's gland. Whereas in male, there are the seminal vesicles, prostate glands is there, vulvourethral or the Cooper's glands are present in case of male. Okay. So next is the opening, the MCQ, the opening of Bartholin duct are situated in the, where it is situated, the Bartholin duct. So as I told in the previous, Bartholin gland is present in male or female. That means that it is mainly present in the female reproductive organ. It is part of the accessory organ or accessory glands of the female reproductive system. Okay, Bartholin gland. So where it is opening? Is it in the vagina, uterus, superficial perineal pouch, or the vestibule? Which one is the correct answer here? Opening of Bartholin duct. So here, that is the vestibule. Okay. So now let's just see where is the vestibule. So here you can see the vestibule region. So here, this is the Bartholin gland, these two. Okay, they are the P-shaped. There are two in numbers, P-shaped Bartholin gland. This is the gland. There is the duct, and this duct will open in the vestibule area. Okay. So here, this Bartholin gland, what is it? It is also known as the greater vestibular gland. And it is two pea-sized gland. That means two in numbers. And what is the size? It looks like size is looks like a pea-sized gland. Okay, and it is also homologous to, it is very important, which is homologous to the bulbourethral or the Cooper's gland in male. So that means you may get the questions in all the MCQs like bulbourethral or the Cooper's gland. It is, I mean, similar to the female, which gland? That is the Bartholin gland. Okay, that is a homologous, means a similar type, which is the, in case of female, that is the Bartholin gland. But in female, I mean, in male, that is the, it is this Bartholin gland, it is homologous to bulbourethral or the Cooper's gland in case of male. And the cyst. When does it develop? Cyst. And I'm talking about that one, that is the Bartholin gland. Usually it is present, Bartholin gland. But what about the cyst? Cyst means something like there is the accumulation of the fluid. So what will happen? That whenever this gland, I mean, this duct is blocked, okay, like maybe due to some infection or from what. So if this duct is blocked, that means the fluid will not come out. Okay, so that's why what will happen? This gland, there is a development of the fluid. So this fluid will develop and it leads to the cyst. And then the size of this pea-shaped Bartholin gland, it will also increase. Usually the size is very small, pea-shaped. But afterwards, when it becomes a cyst, you can see here that is called the Bartholin. The size will increase and that part is called the Bartholin gland cyst. How it will develop? Due to the blockage of the duct. Bartholin duct will get blocked either due to infection. So, and that's why it results into Bartholin cyst. So what is the treatment? Treatment is the marsupialization. That is also important. Marsupialization, what does it mean? That is the removal of the suture and the suturing. Okay, removal of the cyst will be removed and they will suture the duct. Okay, that is called the marsupialization. Okay, it's all about the Bartholin gland. Next is, which of the following is the normal position of the uterus? Is it retroverted and reflected, anteverted and antiflexed, retroverted and retroflexed, retroverted and antiflexed? So what is the normal position of uterus? The question is asking the normal position of uterus. The four options are seen in the screen. You can tell the answer, that is whether it's retroverted and reflected, anteverted and antiflexed, or retroverted and retroflexed, or retroverted and antiflexed. So here the correct answer is anteverted and the antiflexed. That is the normal position of the uterus. So here you can see this is the normal position. Okay, here you can see the pubic bone. This is the sacrum. Okay, from here there is a vaginal opening, cervix, and this is the uterus. The shape is normal uterine shape. Okay, anteverted and antiflexed. And here you can see the bladder. So in case of anteverted, means it will be flexed. Anteverted means before. Okay, and it is called anteverted and antiflexed. Anteriorly it is a little bit flexed. Okay, so here retroverted means what will happen in case that, in that case, that is the abnormal condition. In that case, what will happen? The uterus, the shape, I mean the position will be retroverted to backside, this like this. And retroflex means backside, it will flex like this. Okay, it will go and it will flex like this. So that is called the retroflexed. So by here the normal position is anteverted and antiflexed. And the angle of two things, that is the angle of flexion and angle of version, antiversion. So angle of flexion, antiflexion, that is 125 degree, whereas angle of antiversion, that is version, angle of version is the angle is 90 degree. Okay. So next question, uterine pacemaker is situated at corner of uterus, cervix, isthmus, body of the uterus. So as we all know that pacemaker of heart, right? That is SNO is the pacemaker of heart. So similarly, in female also, there is a uterine pacemaker. So where is it situated? Uterine pacemaker. So by the term itself is saying uterine pacemaker. That means it will be in the uterus only, not in any other place. So where in that position also, in uterus also, in which side? Okay, is it in the corner of uterus? Whether it will be in cervix, isthmus, body, or the body of the uterus. Uterine pacemaker. Here the answer is corner of uterus. That means the uterus is situated at the corner of uterus. So what is uterine pacemaker? That is why it is called the uterine pacemaker. Because it is responsible for initiating contractions during labor and is generally believed to be located in the fundal region. That is the top of the uterus. Okay. So here you can see this is the uterus and this part is called the cornua. So here this one, it is the uterine pacemaker. It is also called as the uterine pacemaker. Okay. Next is the thickest layer of the uterus. So endometrium, myometrium, perimetrium, or peritoneum. So which one is the thickest layer of uterus? So just see this image. In uterus, there is mainly three layers. The outer part, perimetrium. Okay. And inner myo means middle part. M for middle. Myometrium and endo, that is the inside layer. This one yellow part is the endo. So by seeing this image also, you can easily say like which is the thickest layer of uterus. That means the answer will be myometrium. Okay. So now let's see about the uterine wall. It consists of layers, three layers from outside to inwards. So outside to inwards, as I have shown in the image, that means from outside, that is the parametrium or perimetrium. That is the outside layer. It is a serous coat which invests the entire organ except on the lateral borders. The perimetrium is intimately adherent to the underlying muscles. Next is myometrium. It consists of myo, that means the middle part. That is, it consists of thick bundle of smooth muscle present. Muscle fibers are there. They are held by connective tissues and are arranged in various directions. So during pregnancy, what will happen? These layers of various smooth muscle fibers, they will have three distinct layers. It can be identified, especially during the pregnancy. There is three distinct layers can be identified. That is, outer part will be longitudinal, middle interlacing, and the inner circular. Okay. So next is endometrium inside. That is the mucous lining of the cavity. Okay, that is called the endometrium. Mucous lining of the cavity is called the endometrium, but during pregnancy, that lining we call it as a decidua. Okay, so it consists of lamina propria and surface epithelium. That means endometrium only. It consists of two things, that is a lamina propria and surface epithelium. The surface epithelium is a single layer of ciliated columnar epithelium, whereas lamina propria, it consists of stromal cells, endometrial glands, all these here. Okay, and vessels, some nerves will be there. The glands are simple tubular and lined by mucus secreting non-ciliated columnar epithelial, which penetrate the stroma and sometimes even enter the muscle cord. This is the myometrium. So sometimes what will happen? These stromas, what will happen? They will enter inside the muscle cord also. Okay, so the endometrium, as I have said, during pregnancy, it will be changed to decidua. So during pregnancy, we call it as a decidua. Okay. So next is uterus with the depression is known as, is it an arcuate uterus, bicornuate uterus, uterus didelphys, or the septate uterus? So this is a normal type of uterus. Okay, and this is the didelphys. Here you can see the septum. Okay, two. Di means the two. And next is arcuate. Here you can see there is a bit depressed part on the fundal region, just a depressed like this. Okay, but it is not completely separated also. And this is unicornuate. That means only one-sided. Next is bicornuate, means both side. Here you can see. And next is septate, means in between there is a septum. Okay, so here the question is asking uterus with depression, that is known as the, here what I said, this is just the depressed part is there at the fundal region, that is called the arcuate uterus. Okay, so next is fallopian tube. It is lined by pseudostratified epithelium, stratified epithelium, ciliated epithelium, or the germinal epithelium. How is it? Fallopian tube. Fallopian tube is lined by, is it pseudostratified epithelium, stratified epithelium, ciliated epithelium, or germinal epithelium? That is the ciliated epithelium, fallopian tube. So now let's see a few lines of fallopian tube. So the fallopian tube, it is also known as the oviduct or the uterine duct. It can be called as a uterine duct. And sulfingitis, that means the term sulfingitis, that means the inflammation of the fallopian tube. So next is sulfingography, that is the study of fallopian tube with the help of X-ray. And what is the function of a fallopian tube? That is it helps in the mobility of the sperm or the ova, and where this fertilization occurs, it occurs in the fallopian tube only. So zygote develops in the fallopian tube. And another term, that is the PEG cells. It is also important for your MCQ, PEG cell. Where do we get the PEG cell? In which organ? In which site? Or that means the type of non-ciliated epithelial cells which is found in the fallopian tube. Okay. So here, this is about the fallopian tube. Now let's see the parts of fallopian tube. Okay. Here you can see first is intramural. That is it is the narrowest part. Here, this part. This is the fallopian tube. So it is divided. Okay, first is intramural. This is the narrowest part. And it passes from the muscular wall of the uterus, and the diameter is very small, that is the 1 millimeter. Okay. Next is isthmus, that is another which connects the narrow part, which connects ampulla with ampulla with the intramural. Okay, or you can say that the uterus. Next is the ampulla, that is the important one. What is the ampulla? This is the longest, and the ampulla is the longest and the widest part of the fallopian tube. And where is it situated? It is situated between the infundibulum and the isthmus. Between the infundibulum and the isthmus, there is the ampulla. Okay, and the most common site for fertilization, that is the ampulla. So the where does the fertilization occurs? It occurs in the fallopian tube. So if you go more specifically, like in which part of fallopian tube, that will be the ampulla, the fertilization occurs. Okay, that is why it is the longest and also the widest part. Next is infundibulum. You can see the funnel shaped end of the fallopian tube. It is closest to the ovary, and there is a finger-like projection which is called the femori. Okay, so all right, everyone. So here there is a very good news for all of you. Here just a quick and exciting update about the online batch which we are starting from December 8th. Okay, so this batch 8 admissions are open now. So it's mainly a 4-month fully online course. Especially it is designed for Norcet, Neigrihms, RRB, ESIC, and any CRE aspirants, and also any types of competitive examinations. And this batch is starting from 8th December 2025, and the classes will be held from Monday to Saturday except on Sundays. And this is purely an online based platform. Okay, and you will be guided. There are very experienced and the expert faculties are there who have helped hundreds of students to clear the exam with confidence. And the most interesting and the special something special is there for our old participants or the old candidates, that you will be getting some discount. Okay, like as a token of appreciation for their trust and continued support. like the amount will be rupees 1000 discount will be there. For more details, you can contact the number which is given below. And also, if you want to register, you can easily scan the QR code provided here. Okay, so I just want to say, like, don't miss this golden opportunity. Learn from your best, prepare smartly, and also move one step closer to your goal with our batch 8. Okay, so next, let's move on to the next MCQ, that is, which of the following is not a function of placenta? That is, hormone production, nutrient exchange, fetal waste removal, direct mixing of maternal and the fetal blood. That is, which of the following is not a function of placenta? Is it hormone production, nutrient exchange, fetal waste removal, or direct mixing of maternal and the fetal blood? Not a function. The question is asking not a function. So the answer is direct mixing of maternal and the fetal blood. So there is no mixing of maternal and the fetal blood. So why? There is so here you can see this part is the maternal blood and this one is the fetal blood vessels are there. But in between there is a barrier, okay? The thin barrier is there. That barrier we call it as a placental barrier is there. That thickness is very thin, okay? So here the placental barrier, it separates the maternal and the fetal blood and it's composed of several layers are there. This includes syncytiotropoblast, cytotropoblast is there. Here you can see this is called this placental barrier. It is composed of syncytiotropoblast, cytotropoblast, connective tissue of the stroma of villus. Okay, and the syncytiotropoblast, this is mainly facing towards the maternal blood. And next, while the fetal capillary endothelium, it lines the fetal blood vessels. And you can see the thickness, it is very minimum, that is the 0.025. Okay, this placental barrier. So the placenta attaches more firmly to uterus and becomes embedded in organs. Muscle wall, organs muscle wall, that is called placenta accreta, placenta increta, placenta perquita, or placenta extracoriolis. Which one will be the correct answer? Here the question is asking, the placenta attaches more firmly to the uterus. It is attaching firmly to the uterus. What will happen? The placenta is going inside the organ's muscle wall. That means uterine muscle wall. It has penetrated the endometrium and went inside the myometrium. Okay, almost. So that, what is it? Is it the placenta accreta, placenta increta, or placenta perquita, or the placenta extracoriolis? Here, the answer is increta. Okay, placenta increta. So let's just have a quick thing like abnormalities of placental attachment. Here in accreta, so normally you can see this one. First one is the normal position. Placenta is coming and it is just, this is the endometrium. Okay, this part is the endometrium. This part is the myometrium and this is the perimetrium. So endometrium, that means in normally the placenta is just on the lining of the endometrium. But in case of accreta, what will happen? You can see the placenta attaches too deeply to the uterine wall. But it does not penetrate but it is not penetrating the myometrium. You can see the color changes. In pink color, almost completely the endometrium they have covered. Okay, but it is not going inside the myometrium. Whereas in increta, what is happening? They have they have already penetrated the myometrium layer also. Okay, that muscle layer also penetrated and inside. And in case of perquita, that means they will, the placenta will cross the endometrium, they will cross the myometrium and also the perimetrium. So just think P is for perimetrium. Okay, that means it has already completed and sometimes it may be attached with the perimetrium and other organs also. Okay, P for perimetrium, just think. And I is for, you just think like increta, how to remember, like inside. Okay, next is accreta. Here you can see increta placenta invades into the uterine muscle, that is a myometrium. Next is percreta. Placental penetrates through the entire uterine wall and may attach to nearby organs, also like bladder, intestine. Okay. Next is these conditions, they are often grouped under the term placenta accreta spectrum. All these together, sometimes they are called the placenta accreta spectrum due to the shared characteristics of abnormal placental attachment. Okay. So next is, in which of the following weeks the amount of amniotic fluid is 1000 ml? In which of the following weeks the amount of amniotic fluid is 1000 ml? 10th week, 12th week, 20th week, and 38 weeks. Here the answer is 38th week. Okay, that is in 38 weeks, that is the amount will be almost 1000 ml. So let's see the normal volume of amniotic fluid. In 12 weeks, it will be 50 ml. In 20 weeks, 400. 36 to 38 weeks, 1000 ml. And at term, it is 600 to 800 ml. In more than 42 weeks, again the volume, from 38 weeks, again the volume will be decreased, like almost 200 ml. Because at that time, what will happen? The placental aging, because this is the almost post-matured patient, baby. So at that time, the placental aging also will occur, and then the absorption also will increase. Baby will swallow more, and the absorption into the baby's body also will be increased. So that's why the fetal urination also will be decreased. So the volume is getting decreased. That is almost, it will be in 200 ml. Okay, so next is the color. The important question, that is the golden color of amniotic fluid. What does it indicate? Indicates to, is it RH incompatibility, meconium stained, post-term, or normal color? Golden color is a normal color, or is it seen in post-term or the post-maturity, or meconium stained, or in RH incompatibility? Here the answer is golden color of amniotic fluid is seen in RH incompatibility. So now let's see the abnormal color of amniotic fluid, which is very, very important. That is greenish. That means it is mainly seen in case of meconium stained, the amniotic fluid color will be greenish. And golden color in case of RH incompatibility, and greenish yellow or the saffron color in case of post maturity, and dark colored, or there is a concealed accidental hemorrhage, and dark brown or the tobacco juice will be seen in IUD. Okay. Next is the fetal skull diameter that extends from the chin to the highest point of the vertex is called. What is it? The name of the diameter? The fetal skull diameter that extends from the chin or the mentum to the highest point of the vertex is called the, is it submentobregmatic, occipitofrontal, mentovertical, or suboccipitobregmatic? Which one will be the correct answer? Here the answer is mentovertical. Okay, so the mentovertical, just think the chin here we can also call it a mentum. Okay, so that means V for vertex, or the you see V, that means vertical. So that means M and V, mentovertical. The answer is mentovertical. So the mentovertical diameter, it is the longest diameter of the fetal skull, and it is measured from the chin to the highest point of the vertex. Okay, so here you can see the fetal skull. This part is the vault, okay, light blue. And here you can see the face, chin, or the mentum. This part is the base, face. Here is its front is the sinciput. This part is called the vertex. Here, from here at the back side is called the occiput. And there is the suboccipital region is also there. Okay. And if you see some bones are there, like frontal bones, parietal bones, temporal bones are there, occipital bones. Okay. Next is like there is mainly two important fontanelles are there. Okay, there is the two important, mainly anterior fontanelle, which is also called as the bregma, or posterior fontanelle, which is also called as the lambda. Okay, and there are some sutures are there, like coronal sutures, and here is lambda sutures also here. I will tell you in details. Here you can see this is the front part and this is the occiput, means back part. Okay, so here between two frontal bones there is a suture that is called the frontal sutures, and these parietal bones and frontal bone is separated by a suture. Okay, and next is the coronal, this is the coronal sutures, and next is two parietal bone, the two both side parietal bone that is separated by a sagittal sutures, and there is a lambda suture which separates occiput with the parietal bone. Okay, this one I have already told. Next is diameters. Okay, here you can see one by one. Let's see the suboccipitobregmatic. Okay, this is subocciput. This region was called occiput here, and sub means down. Okay, here suboccipitobregmatic. Subbregma means the fontanelle part. Okay, so here this diameter is called this diameter is how much? It is 9.5 centimeter. Okay, and next is suboccipitofrontal. From here to frontal, this is the frontal bone part, frontal part. This is the suboccipitofrontal. It is 10 centimeter, and occipitofrontal. Okay, occiput, from occiput to front part, that is the 11.5 centimeter, and the highest point, that is the mentovertical. Which one is called the mentum? This part, chin part. Okay, and his mentum, mento, from this part I have told you that is the vertex, so vertical. From mentum to vertex, that is the mentovertical diameter, that is the longest or the highest point. Okay, that is, what is this? It is the 14 centimeter. Next is submentovertical. Okay, submentovertical, it extends from the floor, this from here. Submento vertical means from here to here it will go. It is almost 11.5 centimeter, and submentobregmatic, from submentobregmatic this one, that is 9.5 centimeter. So in this, here in diameter of fetal skull, you just have to remember the names also, and also the diameter, okay, centimeter, and which one is the highest point. So this is important for you all. So which of the following is the most favorable pelvic shape for vaginal birth? Which one is the most favorable pelvic shape? Platyploid, android, anthropoid, and gynecoid. Here the answer will be gynecoid, that is the female pelvis. Okay, so here gynecoid, that is the female pelvis, most favorable. Why? It is rounded and inlet is rounded, that they has an adequate mid pelvic space. The space is very adequate for the childbirth, and because during labor, there's so many process the baby has to undergo, right? Descent, so many things are there, flexion. So that is why there's the adequate space for the baby during the childbirth, and the wide outlet making it conducive for the fetal descent and the rotation. The ischial spine, this is the ischial spine, they are less prominent, and the transverse diameter is more than the anterior posterior. Transverse diameter is more than the anterior posterior diameter. It allows the normal childbirth with ease and is more suitable for the childbirth. That is why there is this gynecoid pelvis is very good for the normal delivery. Okay, so there are some other types. Let's see. There is the android pelvis, which is a male type of pelvis. Okay, like it's a heart-shaped, and is a male type, or the wedge-shaped pelvis. That name is android pelvis. Heart-shaped inlet with a narrower inlet. It has convergent side walls, is convergent, and the prominent ischial spines are prominent. Transverse diameter is more, this diameter is more than the anterior posterior. Okay, and it can make very difficult for the baby to descend, and that is why it is, if sometimes if normal delivery also occurs, then it will be very difficult. Okay, so it is mainly seen in case of dystocia, dystrophia syndrome. Okay. Next is anthropoid. That is it is a oval shaped. This pelvis is having the oval shaped inlet. Just you have to see the image also. It will be useful for your image based question also. And anterior posterior diameter, by seeing this image only, you can say this APA. Anterior posterior diameter is longer or the wider than the transverse. Straight side walls, long sacrum, narrow pelvic canal. There is a more chances of occiput posterior. That means this is this part. There is a more chances of occiput will be on the posterior side. Okay. And phase to pelvis delivery, and while vaginal birth is often possible, but it may lead to a very longer labor process. So next is platyploid. That means there is this inlet is flat shaped inlet. So 3 point I have told: wedge shaped, that is the android pelvis, or the male pelvis, that is android. And next is anthropoid, that is the oval shaped inlet, and flat is the platyploid, that is the flat shaped inlet. Okay, the transverse diameter is wider than the anterior posterior diameter, and it has divergent side walls, and ischial spine are not prominent. It's less common and is also associated with difficulties in vaginal delivery. And lastly, they may require the cesarean section also. Okay, next is, what does a zero station indicates during labor? Zero station. That means the fetal head is at the level of ischial spine, is 1 centimeter above the ischial spine. Fetal head is 2 centimeter below the ischial spine, or the fetal head is at pelvic inlet. So by seeing this image also, 0. That means where it will be. It will, the next is -5 and +5. Okay, like it will be -0, -1, -2, -3, -4, -5. So that means, what does it mean? What does zero station means? That means the fetal head is at the level of ischial spine. Okay. So station refers to the relationship of the fetal presenting part to the ischial spine. So there is a negative station and positive station. Negative station means with 5 being the highest and 0 even with the spine. That means the representing part is above the ischial spine. Okay. And whereas positive means it has already started to engage, or the crowning has started. So next is, there are some obstetric grips which we need to keep in mind, mainly 4 obstetric grips, or we can also call as the leopard maneuver. First is the fundal grip. Here you can see fundal grip by image. Second is the second leopard maneuver, that is the lateral grip, or this is also called the umbilical grip. Next is poly grip, that is the third leopard maneuver. This is called the poly grip. Third leopard maneuver. And the pelvic grip, that is the fourth leopard maneuver. So during this examination, in these 3 cases, A, B, and C, what will the examiner will be facing towards the mother's face. Okay, but only in during this case, like at the last one, in fourth leopard maneuver, all the pelvic grip, the examiner will face towards the mother's feet. Okay. Next is, this is convergent and divergent. Which one is convergent? That convergent means this one, converging. Okay, when examiner hands placing, that means these two will be converged. That means the head is still not engaged. Or whereas if this, while doing examination, if the examiner hand gets diverged, that means the head is already, baby's head is already engaged. Okay, so you can see the baby head already coming down. Engagement means when the greatest horizontal plane, the biparatal, has passed the plane of the pelvic beam, the head is said to be engaged. Okay, so you can see this one image also. So once again, I'm telling, like this 8th batch for new NC, we are starting Northeastern online nursing coaching, which is completely an online based platform. We are starting our 8th batch admissions now, and it is mainly a 4-month online course for all the aspirants: Norcet, Neigrihms, RRB, ESIC, any CRE preparations, and any other types of competitive examination. It is mainly for them. And the course is starting from 8th December, and it will be mainly from Monday to Saturday, and excluding Sunday. Okay, And a very good news for our old participants, like there is an extra discount, rupees 1,000 discount for our old participants because of their consistent support and for believing us, especially for the faculties. And for more details, you can contact the number given provided here. And also, if you want to register, you can easily scan the QR code which is provided here, and you can scan and you can register. So if you are planning to appear in the upcoming exams, so you should not miss this chance, and it's a very great opportunity to prepare with the expert and the experienced faculties from this institute. Okay, so next is we'll just see some labor. Normal labor means a series of events that take place in the genital organs in an effort to expel the viable product of conception, that is out of womb through the vagina into the outer wall, that is called the labor. And delivery means it is the expulsion and extraction of a viable fetus out of the womb. It is not synonymous with labor. Delivery can take place without labor as an elective cesarean section. Delivery may be vaginal or either spontaneous or helped or the aided, or it may be abdominal also. Okay, so normal delivery means the term normal delivery is also called as euthanasia. There are some criteria of normal delivery. That is, it should be spontaneous in onset. It should be at terms with vertex presentation, with undue any prolongation, without undue prolongation, and natural termination with minimal aids, and without having any complication affecting the health of the mother and of the baby. So any deviation from the above criteria, that is called the abnormal labor. That means the abnormal labor, it is termed as a dystocia. There's two terms, eutosia and dystocia. Eutosia means the normal labor and the dystocia means the abnormal labor. Okay. So which of the following defines the first stage of labor? First stage of labor, the expulsion of the baby from the birth canal, delivery of the placenta and membrane, onset of regular uterine contraction leading to cervical effacement and full dilation, and the period after delivery of baby and before the expulsion of the placenta. The first stage, that means the onset of regular uterine contraction leading to cervical effacement and full dilatation. That is the correct answer. So the stages of labor, it is also called the cervical stage. Which stage is called the cervical stage? That is the first stage of labor, starting with true labor pain, onset of true labor pain with the full dilatation of the cervix. Primigravida, it is taking almost 12 to 14 hours, and in multipara it is 6 to 8 hours. Okay, next is phases, like latent phase is there, active phase, and 3 phases, transition phase are there. So the phases, different characteristics. Like I said, latent phase, active phase, and transition phase. In latent phase, the cervical dilation is 1 to 3 centimeter, in active 4 to 7, and in transition phase, in the last phase, that is almost 8 to 10 centimeter. Contraction is in latent phase, that is mild, irregular, and maybe infrequent or unnoticeable also. But in active phase, that is, it becomes more stronger than the latent phase, more regular, and it will occur more frequently, every 3 to 4 minutes. And in transition phase, it will be more intense, strong, and it may feel the contraction may feel, the continuous contraction may be there. It occurs every 15 to 30 minutes, 3 to 5 minutes, and every 2 to 3 minutes, the contraction will occur, and it will last for a longer period also. Okay, that is in transition period almost 60 to 90 seconds. And in active phase, it will occur every 3 to 5 minutes, and the contraction will last for 45 to 60 seconds, almost 45 to 60 seconds. And in the latent phase, that is, it will the frequency will be 15 to 30 seconds, but it will last for a very few seconds, that is 15 to 30 seconds only. And in latent phase, the mother will be okay, that is the talkative and okay, relaxed only. But in active phase, fearful and anxious. In transition phase, mother is out of control. Okay, because that time it will be, the contraction will be very strong and very pain will be there, so the mother will be out of control. So what marks the end of second stage? That is full dilation of the cervix, Delivery of the placenta, expulsion of the baby from the birth canal, beginning of the recovery period from the mother. So you can just delete this one. That is full dilatation. It is not. Whether it is end of second stage, delivery of the placenta, expulsion of the baby from the birth canal, or the beginning of the recovery period. That is the expulsion of baby from the birth canal. Okay. So the second stage, like it starts from full dilatation of the cervix, not from the rupture of the membrane. Just remember, okay, full dilatation of the cervix, but not from the rupture. Ends with the expulsion of fetus from the birth canal. In priming gravida, it lasts for 2 to 3 hours, and multigravida, it will take 30 minutes. Second stage of labor, that means expulsion of the fetus. So phases of second stage, that is two phase, that is propulsive and expulsive. Propulsive phase, that means the full dilatation up to the descent of the presenting part to the pelvic floor. Whereas expulsive means expulsion, that is, it is distinguished by maternal bearing down effect and ends with delivery of the baby. The time in the expulsive phase is 20 to 30 minutes in primary, and in multigravida it is almost 10 minutes. Okay. So the events in the second stage, that is, we know like engagement is there, descent, engagement, descent, flexion, internal rotation of the occiput, and crowning, and also delivery of the head by extension, restitution, external rotation, and lastly the delivery of shoulder and trunk by lateral flexion. Because this descent, it will be occurring throughout the process. And you can see easily, you can just remember this one. Okay, mnemonics like everyday funny infants, crown easily resting every limb. Okay, you can just with initial you can try to remember the stages. So the placental separation and membrane are expelled in second stage, first stage, third stage, and latent phase. In which stage placental separation and expulsion takes place? Not in the first stage. In second stage, what it was? It was in the delivery, till the delivery. That means the third stage. Okay, it starts from expulsion of the fetus and with expulsion of the placenta and the membrane. 15 to 20 minutes in primary and both multipara. But in case of active management with the help of our healthcare provider by giving any medication and all, it will take only 15 minutes. Okay. So there are some signs of placental separation. How you will understand that the sudden gush of blood into the vagina will be there. Uterus becomes more globular form and palatable. That is the earliest sign. Okay. Lines of separation. Placenta, that is in the zona spongiosa. There is two sign, that is Schroeder sign and Kushner's sign. That is the, what does it mean? That is the fundal height raises as the placenta separate and move to the lower uterine segment. That is also called the fundal elevation, Schroeder sign. Next is Kushner's sign is there is the absence of umbilical cord retraction when the pressure is applied to the suprapubic area. So there is two methods in placental separation. One is Sulge method and another one is Duncan method. Sulge means here by seeing, you just see the image. Separation is from the center, placenta separation occurring from the center. Whereas in Duncan, the placenta separation is started from the peripheral side. Okay. So the bleeding will be seen only in case of Sulge, because in the center part only placenta got separated. So all the bleeding will be accumulated here. And the bleeding can be seen only after complete separation of the placenta, the bleeding can be seen. But whereas in case of Duncan, what will happen? The bleeding can be seen from before only, when separation has started, because the separation is starting from the peripheral region. There is a formation of retroplacental cord. There is a chances of clot formation is there because all the bloods are getting accumulated. There is, in case of Duncan, there is no retroplacental clot formation. Shiny fetal site present first. Fetal site will be presented first and maternal site can be seen first. Okay. The most common method is a Sulge method, this one. That is why there is a more chances after placenta separation, there is a gush of bleeding can be seen. Why? Because the placental separation is occurring in the Sulge method in case of this one. Fourth stage, that is the stage of observation after expulsion of placenta, and the duration will be 1 to 4 hours. Okay, during this period, maternal vital signs, uterine contraction, any excessive vaginal bleeding is there or not, and also baby has to be monitored. Okay, next is the Bandel's ring. What is it? Bandel's ring is the physiological retraction ring, pathological retraction ring, or a pathological retraction contraction ring, or physiological contraction ring. Bandel's ring, that is pathological retraction ring. Okay, here you can see this is the Bandel's ring. It's a pathological condition. It's a pathological constriction or ridge in the uterus that forms during obstructed labor, marking the junction between a thickened, contracted uterine segment, upper uterine segment, and a thinned, distended lower uterine segment will be thinned, and it is a dangerous sign of prolonged labor. There is a more chances of the prolonged labor is there, and if left untreated can lead to the uterine rupture also, and it is very life-threatening even for both mother and the baby. Okay, this ring can be seen and felt abdominally as a group and potentially rising the level of amniotic. So by from outside, if you see that time also what will happen, you can see like this, the uterus abdominal size will be like this. Okay, I mean like this. So here this part is called the, from outside also it can be visibly seen. So this one here is the Bandel's ring, which is a pathological retraction ring. Okay, so mechanical stretching of the cervix leading to increased uterine activity is known as mechanical stretching of the cervix leading to increased uterine activity is known as that is the Ferguson reflex. Okay, next is Ridgen maneuver is done in which case for delivery of the head in normal labor, occipital posterior position, for delivery of the soldier after coming head in breech presentation, or for delivery of legs in breech. Maneuver, Ridgen maneuver. That is, here this one is called the Ridgen maneuver. That is for delivery of head in case of normal labor. That is called the Ridgen maneuver. Okay. Oh, a 28-year-old prima gravida at term presents to the clinic for a regular checkup. On examination, fundal height is equal to period of gestation and the head of the fetus is non-engaged. What is the most common cause of this finding? Transverse lie, deflex head, brow presentation, or bridge? And answer is deflex head. Okay, so there is the most common causes of why the unengaged head. 40% it is idiopathic, that is unknown, unengaged head. And deflex head, that is next is 28% chances, that is the deflex head, that is the causes. And next is CPD, that is cephalopelvic disproportion in 13%, and loop of cord around the neck in case of 6%, and placenta previa in 5%. So in these options, only deflex head was there. First first commonest cause was unknown, that is almost 40%, but the 28% is the deflex head. Due to the deflex head, that is why here the answer will be deflex head. So next is descent of fetus is facilitated by all except extension and straightening of fetal body, pressure of amniotic fluid, uterine contractions, well flexed head. Descent of fetus is facilitated by all except. Which one will be the answer? So well flexed head. Okay. The descent of fetus is facilitated by uterine contractions, contraction of maternal abdominal muscles, extension and straightening of the fetal body, and pressure of the amniotic fluid. So next is, what is the passenger in the context of 5 P's of labor? In case of 5 P's of labor, what is passenger? That is the uterine contraction and pushing effort, maternal pelvis, fetus and the placenta, psychological state of the mother. Answer is the fetus and the placenta. So the 5 P's, that is for the successful vaginal birth, is the first is power. Power means the force of uterine contraction and the pushing down efforts. Passageway means the mother's pelvic anatomy. Okay, the pelvis, whether it's a gynecoid pelvis is there or other abnormal or other types of pelvis are there. Passenger means the fetus size and the position, and the position is the mother's body position during labor. And the psyche means the psychological and the mental state of the and the emotional state of the mother. Okay. Next is show. Show in labor refers to discharge of amniotic fluid, expulsion of mucus, plug mixed with blood, rupture of membrane, and passage of vernix. That is expulsion of mucus, plug with the blood. Okay. Next is, a patient is experiencing shoulder dystocia. Which of the following maneuver, just have to tell the name of the maneuver, involves applying downward and lateral pressure just above the pelvic bone to rotate the anterior shoulder and facilitate the delivery. That is Robert's maneuver, Heimlich maneuver, Rubin's maneuver, or Valsalva maneuver. So here you just omit that one. Heimlich maneuver, it is required for choking. Valsalva maneuver is also required, not in this case, that is in case of the forceful exhalation during. Okay. Next is, the answer is the Robin's maneuver. That is Macrobert's maneuver, that involves the hyperflexion of the mother's leg. And Robin's maneuver means specifically describes applying suprapelvic pressure we can apply here of the anterior shoulder. Okay. So once again, I'm telling, like Northeast online nursing coaching will be starting from 8th of December 2025 for our 8th batch. Okay, and this course is completely for 4 months. And this course, I have already said, like this course will be from exclusively on online platform, and it will be from Monday to Saturday. Only on Sunday there will be no class. And for our old participants or our old candidates, there is an extra ₹1,000 discount because of their constant belief in us and all the faculty. And if you want to register for this online class, you can scan the scanner code which is provided in the screen. And also for more details, you can just screenshot this apps and screenshot this slide and take the number, and you can contact for more details from this number. Okay, so this is all for today. Thank you, everyone.